Now we proceed to the much awaited session, which is the oral abstract presentation. We'll be getting divided into two halls. Hall A will be for the clinical neuro-oncology abstract presentation, and the basic and translational research, as well as the AIYA neuro-oncology research, will be in Hall B. So I request the presenters of clinical neuro-oncology research to please stay back over here. May I request the chairpersons to please come up on the stage. Dr. Neenu Gupta, she is the professor radiation oncology and head of the department at Swami Rama Himalayan University, Dehradun. And Dr. Shamim Ahmed, he's a senior consultant neurosurgery department at Guwahati. So each presenter will get 6 minutes for the presentation, followed by 1.5 minutes for question and answers. So I request the chairpersons to please invite the presenters.
Thank you, organizers, and we had all the best wishes for all the presenters. We had, I think, first Afreen is not there. We can call number 2, Anindita Das. Please, you can come. And the title of the paper is Lymphopenia during image-guided pencil beam scanning proton beam therapy for consecutive glioma patients and initial experience from India.
Good morning, everyone. So today I'll be presenting about lymphopenia during image-guided pencil beam scanning proton beam therapy for consecutive glioma patients. This is an initial experience from India, from the Apollo Proton Cancer Center. Just a background regarding lymphopenia and glioma. It has been well established that patients on treatment for glioma do have lymphopenia. And unlike what is thought usually, temozolomide and steroids are not the only culprits. Radiation alone has been found to be responsible. Multiple studies have shown that even patients who are treated with radiation alone do have lymphopenia as well, and this has been shown to have a survival outcome in terms of worse survival, which is maintained in a recent meta-analysis that was published. So coming to the question of how does radiation cause lymphopenia, since we know that the brain is considered to be an immune privileged site when there is not much lymphatics, the main cause is a direct toxicity on the circulating lymphocytes. So the toxicity is actually proportional to the normal tissue exposure, including low dose exposure, effective field size, and cumulative time, that is fractions. So coming to the low dose exposure area, studies have actually shown that moderate dose exposure like V20 gray and V25 gray have been found to correlate directly to acute severe lymphopenia. And I mentioned earlier that brain is considered an immune privileged site, but actually recent data has showed that there are indeed CNS lymphatics mainly centered around the dural venous sinuses. So radiation to these can also cause the lymphopenia. So when we know the cause, how can we reduce it? By a smaller target size, by less normal tissue exposure, less number of fractions, and by avoiding radiation to the larger vessels of the brain. So because of its sharp dose fall off, then the question comes on whether proton therapy can reduce the incidence of this severe lymphopenia. And a recent phase 2 trial from Mohan et al. Has actually shown that protons caused lesser grade 3 and above lymphopenia, better mean nadir ALC, and a lesser whole brain V20 gray compared to photons. And an ongoing NRG-BN001 trial will probably give us the answer on what is the survival implication of the same. So what about Indian data? This would be the first report from India regarding proton therapy in terms of lymphopenia and gliomas. And the primary objective was to estimate the incidence and severity of lymphopenia in these patients, which we have graded as per the CTCAE version 5. So normal was considered 1,000 and more. Grade 1 and grade 2 comprised of mild lymphopenia, which was 801 to 1,000 and 501 to 800. And severe lymphopenia is grade 3 and above. Grade 3 is 200 to 500 lymphocytes per mm3, and grade 4 is less than 200. So we included all grade 2, 3, and 4 gliomas who received proton beam therapy at our center between Jan 2019 to December 2021. And these were both newly diagnosed and re-irradiated cases. For a parallel comparison group, we have included all the glioblastoma patients who were treated with helical tomotherapy in this period at our center. Demographics-wise, most of these patients were adults, and a significant proportion, 70%, were actually males. All of them had undergone surgery to some extent, a minor proportion being only biopsy, and the most of them had undergone either subtotal resection or gross total resection. About 51 of them were radiation naive, and 21 of them had been re-irradiated. The lymphopenia rates in these two groups did not differ in our population. A major percent, 61%, were WHO grade 4 cases, and the others were equally divided between grade 2 and grade 3. So when we analyzed the lymphopenia rates, we found that the overall incidence of any lymphopenia ranging from grade 1 to grade 4 was 48%. That of acute severe lymphopenia grade 3 and above was only 8%, and there was no case of grade 4 lymphopenia in this population. Mean nadir ALC was 964. So an interesting picture came out when we did a subset analysis grade-wise, that all the grade 3 and above lymphopenias, that is the severe lymphopenia, were only in the WHO grade 4 tumors. And when we compared it to the photon group, like I mentioned, there were 44 glioblastoma patients in both the proton and the photon arm. And the incidence of any lymphopenia as well as severe lymphopenia was significantly more in the photon arm. And the nadir ALC was better in the proton arm. We also analyzed the whole brain V20 gray and V25 gray and found that this moderately correlated to the severity of lymphopenia, not just in the proton group, but also in the all patients group. So which proves that reducing V20 gray and V25 gray of the whole brain can have, less severe lymphopenia. And this is just a dosimetric picture to show that the V20 gray and the V25 gray in the photon arm, this is the difference, this in the area of the brain that is irradiated lesser in the proton arm. And when we mapped out the survival curves, the progression-free survival of the patients with any grade of lymphopenia tended to separate out and be worse than patients with normal lymphocyte rates, and this was nearing significance. So in summary, this is the first series from India reporting lymphopenia and glioma patients treated with proton therapy. And prospectively collected CBC data for all these patients showed that proton therapy could reduce incidence of any lymphopenia and severe lymphopenia, as well as the whole brain V20 gray and 25 gray, which in turn are correlated to lesser grades of lymphopenia. And with a relatively short follow-up, patients with any lymphopenia during adjuvant treatment showed a trend towards worse PFS. Thank you.
Thank you, Anindita. And any questions from the audience?
So thank you for the presentation. All these patients have received temozolomide, and we all know that temozolomide causes severe lymphopenia rather than the mediation. So how do you tease out that?
So sir, the patients who had proton therapy as well as photon therapy, all of them got temozolomide. So since there was a difference, and they all got corresponding doses of temozolomide as well. So
match cohort analysis of 44 patients with IMPT and IMRT, and the lymphopenia was significantly worse in the IMRT than IMPT. So, and both received temozolomide, so there is no difference in that. So there is a trend, it's just a proof of principle study, but there seems to be some correlation of lymphopenia with PFS.
So we had one more question from Dr. Sapna. And,
I think you showed that grade 4 is having more lymphopenia as compared to grade 1, grade 2.
More severe lymphopenia,
More severe
grade 3 and
lymphopenia.
above.
And what about the tumors which are in the periphery? They will obviously have more skull exposure to the radiation as compared to the midline tumors.
Yeah, maybe that we have not seen.
Because you have not specified the location of the tumor.
We can check that, but hopefully they will be equally matched between IMRT and IMPT. So we can check
I think that should be
can be
checked.
done. That
Yeah.
can be done. Interestingly, lymphopenia was seen only in grade 4, not in grade 2. Grade 2.
Thank you, Dr. Sapna and Dr. Anindita. Good idea for subgrouping, classification, and result. Thank you.
Thank you.
I think we had 6 minutes for presentation and 1 minute for question answer.
Hello. Next speaker is Jwala M. The topic is intercepting the crosstalk between neural stem cells and glioblastoma multiforme.
Good morning, everyone. I'm going to talk about intercepting the crosstalk between neural stem cells and GBM. We know GBM is the most common primary adult tumor with a very dismal prognosis. Sorry. So over the last decade, we have seen that with the advent of better understanding of the tumor biology and with more therapeutic management, we've seen that like maximal safe resection with 5-ALE and diffuse cancer imaging and the use of temozolomide after the Stupetol trial, the survival rates have increased in GBM, even younger. Now, this study by D'Souza et al. Had compared the survival rates of GBM across 2 decades from 1999, 2000, and 2009 and 2010. And it had shown that the survival rates had improved in the short-term survival, but long-term survival still was elusive. Now, what happened in the next decade? The last decade saw newer trials evolving using the targeted therapies, immunotherapies, oncolytic viruses, and all these just to improve the clinical outcome in GBM. But all of these showed only anecdotal success, and none of them proved any concrete results. Now, various mechanisms of treatment resistance were seen in GBM with respect to when we analyze the GBM with its tumor microenvironment. And the mechanisms of treatment resistance were the blood-brain tumor barrier, the heterogeneity within the clonal cell population, the hypermutation, the Warburg effect, and the self-renewal by the cancer stem cells itself. So in this study, we would like to throw some light into the cancer stem cells and how it makes GBM invincible. The neural stem cells are specialized or unique stem cells in the brain, which have self-renewal properties and also multidirectional differentiation. And the neural stem cells in the brain are present in the subventricular zone of the along the lateral ventricles and also in the subgranular zone of the dendritic gyrus of the hippocampus. And the trials have already established the role of neural stem cells as being the origin of glioma, but they have also been associated with tumor progression and also even recurrence. Now, this is a meta-analysis by Mystery et al., who showed that, who analyzed the survival outcomes depending on the GBM contact with the neural stem cells in subventricular zone and those without any contact with the lateral ventricle or the subventricular zone. So they found that the GBM with contact with the subventricular zone in the neural stem cells had shown poorer survival in both overall survival as well as progression-free survival. And the evidence related with poor prognosis of those neural stem cells and GBM is established. But there are also studies which have shown absolutely no correlation between the stem cells and survival, like this one with published by Slotman et al., where irradiation of the potential stem cell niches and subventricular zone was evaluated, and there was no correlation found between the ipsilateral, contralateral, or the bilateral subventricular zone dose and overall survival. So, in a quest to find out any relation between the subventricular zone and the crosstalk between the neural stem cells and the GBM, we analyzed retrospective data of 67 patients who were treated from January 2016 to December 2019 in our facility. And after excluding all the patients whose follow-up data and MRI images were incomplete, the final study cohort included 45 patients who had undergone standard treatment protocol of an adjuvant, maximal safe resection with surgery followed by concurrent temozolomide and radiation followed by adjuvant radiotherapy. Now, as we said, was contoured as a 5 mm strip along the lateral ventricles, and as given in the Barani et al. Article. And these are the images of the third one is our contoured images of the lateral ventricle, sorry, the subventricular zone. The ipsilateral, contralateral, as we said, were contoured separately, and then dosimetric parametric analysis was done for each of these separately and also the combined, as we said. Now, we categorize the GBM into 4 grades depending on the tumor contact with SVZ and cortex. The grade 1 tumors were having contact with SVZ and infiltrating the cortex. Grade 2 were those with contacting the SVZ alone. And the grade 3 were those with contact to the cortex alone. And grade 4 with no contact with either of these. Coming to the statistical methods, overall survival was taken as a time period between date and diagnosis and death due to GBM. Demographic and the clinical characteristics were analyzed and reported using disability statistics. Overall survival was calculated using the Kaplan-Meier method, and the log rank test was used to test the significance. Cox proportion hazard regression was used for multivariate analysis. The patient characteristics of the cohort include median age was 51 years, male and female ratio was almost the same, and the KPAs, most of them presented with less than 70, and most of them presented with an IDH wild type, that is a primary glioblastoma, and most of them were grade group 1, but that is about 64%. And most of the patients had undergone gross tumor resection. Now, coming to dosimetric details, ipsilateral and combined SVZ details were taken. We took these dosimetric parameters arbitrarily because most of the data regarding the dosimetric parameters are a little ambiguous. So we try to include all the high to low dose regions of the SVZ. The median survival was 8 years and 5 years was 5%.
Fast, your time is moving.
The progression-free survival was 13 months. Now, all those variables which showed significance in univariate analysis was taken into multivariate analysis, and we found that patients who underwent gross tumor resection did significantly well, and that the dosimetric parameters pertaining to SVZ, D95 and D minimum were statistically significant. And the higher doses to SVZ so positively impacted the overall survival in our study. So I would like to conclude by saying that our study showed that the D95 and the D minimum received by the SVZ dose had a positive prognostic impact on our overall survival. And obviously, because of the retrospective nature of this trial, larger prospective trial would be needed to target the SVZ to provide us with concrete answers. Thank you.
Any question?
So, Anindita, Jwala, the contouring was done by the same oncologist?
Sorry, ma'am?
Contouring was done by the same oncologist for all the cases?
Yes, ma'am.
Thank you. Thank you.
Thank you.
We move on to another paper. So Dr. Kuldeep Singh. This topic is biological aggressive pituitary adenomas, a tertiary hospital-based study.
Good morning, all of you. My topic is biologically aggressive pituitary adenomas, a tertiary hospital-based study. As we all know, pituitary adenoma is a neuroendocrine tumor of the adenohypophysis composed of secretory cells with pituitary hormone production. Pituitary adenoma mainly composed of, it includes somatotroph, lactotroph, thyrotroph, corticotroph, gonadotroph, null cells, and plurihormonal. Pituitary adenomas are 10 to 15% of intracranial neoplasm and are third most common primary brain tumor. Pituitary adenomas are considered benign tumors, but approximately 10% of them can have aggressive behavior, and more rarely 0.2% if they present as metastasis. They are classified as pituitary carcinomas, as signs of histopathological malignancies are lacking. Pituitary adenoma mainly occurs in 4 to 7 decades, and women have slightly greater incidence. Majority it occurs in sella turcica within adenohypophysis, and rarely it occurs in extracellular region on pituitary stalk. These tumors exhibit spectrum of clinical behavior depending on their clinical activity and size. With the use of immunohistochemistry, aggressive adenomas can be recognized by their hormonal profile and MIB1 index. MIB1 index is widely accepted marker of proliferation. On basis of gender, hormonal activity, histological and immunohistochemical findings, pituitary adenoma can be aggressive irrespective of MIB1 labeling index, such as lactotroph in males, sparsely chlorinated somatotroph, silent corticotroph, PIT1 positive, plurihormonal adenoma, and recurrent adenoma. The 2018 European Society of Endocrinology guidelines on aggressive pituitary tumor and pituitary carcinoma defined aggressive pituitary tumors as pituitary adenomas that demonstrate radiological invasiveness and an unusually rapid tumor growth rate or clinically relevant tumor growth despite optimal standard treatment in the form of surgery, radiotherapy, and conventional medical therapies. Aggressive adenomas are generally large and invasive tumors that present with unusually rapid growth and that grows irrespective of conventional treatment with surgery, medical therapy, and radiotherapy. Nevertheless, large tumors as well as invasive tumors are not always aggressive, with this definition being possible only after clinical follow-up of these tumors, with growth rate or response to therapies being key point to its diagnosis. The correct identification and diagnosis of aggressive adenomas is of great importance as they are associated with great morbidity and increased mortality. Aim of study is to assess the hormonal profile of pituitary adenomas and study the clinically silent and biologically aggressive pituitary adenomas. Material and method. This is a tertiary hospital-based study of 40 cases of pituitary adenomas. All specimens were fixed in 10% formalin and entire biopsy tissue was processed as per standard guidelines. ISC markers were done after H&E microscopy. ISC were done using primary antibodies against these antigens ACTH, GH, LH, FSH, PRL, and TSH and MIV1. Result. This table shows 40 cases of pituitary adenomas for hormonal profile and proliferation index. And on one side, there is IRC result of somatotroph, gonadotroph, corticotroph, lactotroph, plurihormonal, mammosomatotroph. Total 7 out of 40 cases of somatotroph, 10 of gonadotroph, 9 of corticotroph, 5 of lactotroph, 4 of plurihormonal, and 2 of mammosomatotroph. Of the total 50% of cases subjects with MIV1 labeling index more than 2% were gonadotroph, 21.14 were somatotroph, 14.2% were lactotroph, and both corticotroph and mammosomatotroph 7.1%. This table shows distribution of biologically aggressive pituitary adenomas, and lactotroph are 4 in number, recurrent adenoma 4 in number, plurihormonal adenoma is 4 in number, and silent corticotroph 2 in number. 2 of the lactotroph in male and all recurrent pituitary adenomas are biologically aggressive as well had MIV1 index of more than 2%. And this table shows association between aggressive adenomas and ISC results. 7 out of 22 aggressive adenomas were gonadotroph, including 3 of them being recurrent with high MIV1 leveling index and other 4 as MIV1 level more than 2%. Discussion. Out of total 22 aggressive adenomas, 55%, 14 cases were aggressively only on the basis of increased MIV1 labeling index, and 14 cases were diagnosed as aggressive on the basis of immunohistochemistry as per WHO 2017 criteria. They were in category of biologically aggressive adenoma. Of these biologically aggressive adenomas, 6 cases were high in MIV1, 2 lactotroph in male, and 4 recurrent adenomas. Certain pituitary adenomas are considered as biologically aggressive adenoma, irrespective of MIV1 labeling index on basis of gender, hormonal activity, histological immunohistochemistry. Findings such as lactotroph in male, especially granulated somatotroph, clinical corticotroph, and P1 positive plurihormonal adenoma, recurrent adenomas. 4 recurrent pituitary adenomas were seen in our study. MIV1 labeling index was found to be high in all of the 4 recurrent adenomas. Study by Manish Bora yielded similar results. In our study, MIV1 labeling index more than 12% in 40% of clinically non-functioning adenomas, with one silent lactotroph having MIV1 labeling index of 12 to 15%. Wasberger considered MIV1 labeling index gold standard for the relevance in post-operative management of clinically non-functioning adenoma. Akramullah found that there was an inverse correlation of Ki67 with tumor doubling time in regrowing non-functional adenomas. Conclusion of study: silent and aggressive pituitary adenomas represent a challenging group for tumor. MIV1 labeling index is used as a gold standard for assessing the biological aggressiveness, and the MIV1 labeling index more than 2% is of prognostic significance. However, clinical silent adenomas are also found to be aggressive and can be detected on ISC. Thus, correlation of immunohistochemistry and proliferative index with clinical and biochemical history is an important tool for proper evaluation and may be helpful in further adjuvant therapies which may be needed. Thank you. Reference.
Thank you, Kuldeep. Any question? No.
Thank you for that presentation. I had a question for you. One is that you said that your conclusion that before more than 2% in your study had shown to have prognosis was poorer. What are the parameters? I don't think you presented the follow-up data. How many of those patients recurred? So how did you conclude that the prognosis is poor before the 2%?
Sir, we have linked with the neurosurgery team. And
No, but the data of the recurrence rates of follow-up data. So you will not be able to, how did you conclude that the prognosis is poorer before the follow-up 2%? That's one question. Second question, did you try to correlate any of the preoperative presentation of these patients, whether they had shorter duration of symptoms, whether they had poorer vision?
So it is not included in the study.
You had not.
Thank you, Kuldeep. You can go back and you can check here some of the parameters with your clinicians, how these patients are doing on follow-up. Thanks.
Yeah, the next presenter is Nitin Garg. His topic is awake surgery for resection of tumors in or near eloquent areas of the brain without invasive monitoring for maximal safe resection.
Good morning. I'll be presenting on awake craniotomy in eloquent. This is not moving. This is the awake surgery for resection of tumors in or near eloquent areas without intraoperative monitoring. So as we know, awake craniotomy is performed for tumors adjacent to or in the eloquent cortex, and the aim is maximal safe resection. Intraoperative neuromonitoring is now being routinely used. However, it has significant limitations, one being the cost, and second being the human resource to monitor or manage these machines. There are the modalities which are more commonly used by us, like BTI, fMRI, neuronavigation, and intraoperative ultrasound, and in 1 or 2 centers, intraoperative MRI. So we present our results from 15 till 22 of awake craniotomies without IONM. It's a retrospective data, and there are 50 patients. Important points are the radiological analysis of preoperative and postoperative tumor volume and extent of resection was done by the radiologist independently. Various other parameters were analyzed. Importantly, we analyzed the location of the gliomas with the extent of resection, the intraoperative and postoperative events, the areas of residual, and the correlation of deficit and the location of dissection, that at the point of which dissection, in which area the patients develop deficit. The technique is a sleep-awake sleep, and we use Cal block with clonidine infiltration, and this has helped us to prolong our awake craniotomies to almost 7 to 8 hours. Adjuncts which we use is preoperatively DTI, intraoperatively navigation and QSA. Intraoperative ultrasound we've just started to use, so it's not given us still a comfort zone to use it to help us to guide the extent of resection. The plan is marking of the flap, craniotomy, and then we mark the eloquent cortex once we open the dura, because as we know, once decompression starts, there's a brain shift. And the surgical procedure is we start from the less eloquent areas and gradually go to the more eloquent areas. And we have our anesthetist and a psychologist in the operation theater, and they keep on doing frequent neurological examination. The frequency of this examination is guided by the surgeon. So as the surgeon goes to more eloquent area, the frequency of this testing increases. And we have found that if there is any slowness, the initial response, if there is any slowness in the response, it's a red flag, we wait for recovery and then we proceed. If there is any subtle deficit, again a red flag, we wait for recovery, we proceed. But if there is recurrent deficit on dissecting in that area, or if it's the persistent deficit, we stop. This is how the setup looks, surgical team and monitoring team. And we have divided into 3 groups, the posterior frontal gliomas, the insular gliomas, and the temporal and the parietal gliomas. So we can see that in the superior frontal group, we had 8 patients. The middle frontal group, we had 8 patients. Inferior frontal, 1. Motor cortex, 1 patient. And if we combine the groups or the locations, we had 4 patients in superior frontal, middle frontal, 2 patients in frontal and motor cortex, and 1 patient involving all the areas. Some of the representative examples, this is reaching up to the motor cortex, this is displacing the motor cortex, and this is infiltrating the motor cortex. Now we compare the extent of resection with the relationship with motor cortex, and we find that those who had proximity or they were displacing the motor cortex, the resections were very good, almost 98 to 99%. But if there was infiltration, the extent of resection fell significantly. And intraoperative deficits also followed a similar pattern, that the deficits increased as the tumors were infiltrating the motor cortex. The post-operative deficits, we had some patients who developed deficits few hours to up to 2 days after the surgery. And there was no correlation with the motor cortex and the deficits. So then we analyzed how to correlate the region of surgical dissection and the deficit. And we found that the most common area where the patients end up with deficit, and all of these were reversible deficits, is when we are dissecting in the subcortical tracts. So it is here when we had to stop, there's a small hyperintense signal. Similarly, a preoperative glioma, and as we are dissecting here, the patient had deficit and we had to stop here. So we found that the posterior inferior subcortical area was a very common site of having these deficits, and a warning sign to increase the frequency of monitoring and to restrict the dissection. Second was, if there was infiltration of the motor cortex, as we start reaching towards the motor cortex, the patients tend to have deficit, and therefore again the monitoring increases and the surgeons have to be very careful in dissecting in this area. So what were the reasons for residual tumor? One was functional limitation, if the patient developed intraoperative deficit. Second was the anatomical limitation, if it was extended to the opposite side, into the eloquent cortex, into the deeper areas like basal ganglia or the multi-compartment extensions. But importantly, one important variable was surgeon's judgment. And this, I feel, is an important variable. And as we discussed yesterday, a post-operative MRI will help the surgeon to improve this variable. And the most common locations of residual tumor were in the tumor cavity, either anterior subcortical or inferior subcortical. As we can see here, the inferior subcortical or the anterior subcortical, and sometimes the adjacent cortex also. Coming to insular gliomas, the Berger-Sinai classification, these are the various zones and the tumors in these zones, and these are the representative examples of these gliomas. We could not achieve complete resection in insular gliomas, and some of these patients did have deficits, but again, these were transient. And if we just 2-3 slides, the location of residual was the medial part of the insula, this part, and the posterior inferior part of the insula. And again, these were the difficult to visualize parts. And the cause of residual was again an extensive disease, as in this case, an intraoperative deficit, but again a surgeon's judgment, the medialmost part of the insula or the frontal opercula, as we can see in this area, in this or in this scan, which of course is a variable which can be improved. This patient did have vascular insult, high-grade glioma, and a delayed deficit. So I'll just last 2 slides. This was one study with which I have compared our results by Defoe, and he compared his own results of premotor region without monitoring, with monitoring. And if we see that using a systematic approach and a team approach, the results are almost similar to the one with intraoperative monitoring. So this is what our experience has been, and as we have been year on year improving, increasing in the number of cases, we find that the number of intraoperative deficits are also increasing. It's a paradox, but these are all reversible deficits. So we have got more confident with our team to monitor them, and we are able to aggressively remove these tumors. So to conclude, it can be performed safely. IONM is not essential, and a resource constrained situation, this should be used selectively. Whereas adjuncts are available for planning and intraop resection, and a dedicated team and good communication between surgeon and monitoring team is essential. And post-operative MRI is very helpful in assessing the extent of resection, but also for improving the ability of surgeon to improve over a period of time his own ability to resect these tumors. Thank you.
Any question?
Dr. Nitin, it was a very good presentation, I must say. I have some very basic question that it was a retrospective study.
Yes.
And the other thing was that you told that the assessment was done independently by the radiologist,
Yes.
comparing the pre-op imaging with the post-op imaging.
Yes.
So what was the post-op imaging, and whether it was a CT or it was an MRI?
Yes. So from initial 3 years, it was more often CT scan, but since 2018, we have been doing regularly MRI scan. So yes, there was a difference in the post-operative. I did not present that, but the ability to analyze the post-operative scans was different if we compare before 2018 and to after 2018.
Okay.
And I think that is what I wanted to highlight here, that we as surgeons have to learn from each of these cases. And I think post-operative MRI is an excellent tool. As we were discussing yesterday, extra-operative MRI, which Dr. Rupesh and Dr. Anand, they are following, is finish the case, take them down directly from the OT to the MRI suite, and if there is a residue, come back again. I think that's a very good way wherein intraoperative MRI is not available. But I think Dr. Ali group, who have intraoperative ultrasound, is also a good technique, but we need to develop that skill to be able to use it for better resections.
Thank you, Dr. Nitin. Rest one can discuss during tea session. Thank you. Now we are calling Dr. Pankajkumar Panda, and his topic of presentation is baseline quality of life burden in central CNS tumors treated with pencil beam proton therapy at India's first proton therapy center.
Good morning, everyone, and thank you for the opportunity. I'll be presenting on the baseline quality of life burden in central nervous system tumors treated with pencil beam proton therapy. And a brief background and the general aim is that there's a lot of paucity of data related to quality of life, especially long-term quality of life data in brain tumor patients, and especially in proton therapy with respect to proton therapy. So this is our attempt to study the quality of life in brain tumor patients who are being treated with proton therapy and to prospectively follow them. So the materials and methods are, we collected a data set of 126 consecutive adult patients who consented, and detailed neurological assessment, quality of life using QLQ-C30, BN20 was done. And this was done right before starting the adjuvant treatment. And we divided the patients into 3 subgroups, like high-grade glioma, low-grade glioma, and benign tumors. And statistical analysis was done using non-parametric independent sample t-test, and it was done during SPSS. So this was the study methodology. We screened the patients, then consenting, administrating of the quality of life questionnaires in usually 3 languages. But we had no patients who wanted to do in Hindi. It was primarily English, Tamil, and Telugu. And it was administered by a physician assistant and care coordinators. And it was done at baseline, post IMPT, and 3 months, 6 months. And we are following it up with 1 year, 3 year, and 5 year. So these are the results. And we had almost 158 patients who were eligible to participate, but only 126 patients consented for the prospective study. And almost every one of almost every one of the consenting patients completed the questionnaire, both the QLQ-C30 and the BN20. While at the end of first year, we had a response rate of 75%, and at the end of 2 years, we had a response rate of 64%. And these are some of the demographics data which we have. And the majority of our patients were primary patients, and around only 38% patients were recurrent cases. And also majority, around 70, more than 70% of the patients were for upfront irradiation, while we also had almost 24 patients who had re-radiation. And a majority of our patients were high-grade glioma, And next to them was low-grade glioma, then benign tumors and other tumors were also there. So coming to the analysis of the baseline quality of life scores, as we can see, the global scores of baseline quality of life are in accordance with some of the studies which is there already published. And what we found out is that even before the starting of adjuvant treatment, most of our patients complained of fatigue and pain. And then we did a comparison of the baseline global scores of 126 patients with patient-related factor. And what we found out was that more than 60 years of age patients had a lower global score, which was statistically significant also. And it was well seen across the various histological subgroups which we had divided the patients. And a poorer KPS score performance status also patients had a lower global score, which was statistically significant across all the histological subtypes. And also patients who had taken previously radiation had a lower baseline global score even before starting the treatment again. So these are some of the salient observations which we had for our study, is that elderly patients, as I mentioned, had a poorer score. Patients with low performance status had a lower score across all histologies, and patients undergoing re-radiation had a lower score. And to conclude, it is like patients with malignant recurrent tumors, poor performance status, and patients who has previously been irradiated had significantly lower quality of life scores even before starting adjuvant treatment. So, and our conclusion is that these kind of studies definitely should be done. And what we are doing is we have a prospective study called the PRO-BT study, which is ongoing, and this analysis was a part of the study. And we are prospectively following up all the patients for at least 5 years. And our aim is to collect quality of life data of these patients, central nervous system tumor patients who are being treated with proton therapy for 5 years. Thank you.
Thank you, Dr. Pankaj. Any question from the floor? Yes, there is one question.
So I must congratulate. It's any quality of life scores is really a commendable job to do. As you said that the patients who are elderly, who are having a poor KPS, high-grade gliomas, then recurrent cases, they had a baseline poor scores. So it's just my curiosity, like, it is very much understood that they'll be having a poor KPS. So I mean, they'll be having a poor score. So how, I mean, doing all these exercises, I mean, where are you exactly moving into?
So basically, it's very important to have a baseline reference in any of these patients when we are treating, so that when we are doing a 5-year prospective study, it's easier for us to compare it from a baseline score. So if we have a baseline idea of, like, we may have a variety of spectrum of patients who we are treating, and if and there will be a lot of disparity between the baseline scores of all the subgroups of patients. So that was our main aim, to at least see at the baseline where we are standing, what is the variation in the quality of life scores. So when after 5 years we do the analysis, that will be helpful to compare effectively.
Thank you for that nice presentation. Modify your therapy or your duration of the radiation based on the quality of life. For example, if the person had very poor quality of life, did you feel that they have to have a hypofractionated regimen compared to?
We didn't do that, but the thing is, anyways, like immediately after proton therapy, or maybe we didn't evaluate the quality of life. You mean after baseline quality of life?
So before treatment?
Yeah, before treatment. So
suppose you found that a person had a very low quality of life. Did you feel that, did you have a strategy by which you reduce the fraction of radiation so they didn't have to come so very often to the hospital?
Yes, we did that. Even we have another study which we call the senior study, which we are doing, and we take the consultation of a geriatrician also after the.
Based on your quality
Yes.
of life scores, did you modify your?
Yes, sir.
Based on quality of life.
So, thank you, Dr. Pankaj.
Thank you.
So we are moving.
Yes. Our next speaker is Ayal Malhotra. She'll be speaking on spectrum of medulloblastoma in children.
A very good morning to all of you. I think it's a beautiful Sunday morning, and I'm honored to be a part of this academic feast. At the offset of ISNO, I will be presenting my oral presentation of spectrum of medulloblastoma in children, a single center experience over 10 years. So all of us know that it's the most common malignant brain tumor in children, accounting for almost 25% of primary CNS neoplasms. Age is the major game number, which affects the incidence as it's got a bimodal age distribution. The biology, we know the biology is different in infants, young, and in adults. The presentation of the disease, again, we know adults may have a lateral vermis disease, infants have open anterior fontanelles, so they may present later and different in children. The treatment strategies, we know that less than 3 years, we do not have the option of radiation, and more than 3 years, it becomes mandatory. And we know that there is a paucity of data of medulloblastoma in children in MMIC, and hence the study was undertaken to analyze the same. So we analyzed all these spectrums, and it was a retrospective study of 10 years from January 2011 to December 2021. Children less than 18 years of age or equivalent to 18 years with confirmed diagnosis of medulloblastoma were included. They were analyzed for their demographic and disease detail, the treatment protocol, the response, and the outcome. Survival analysis was done using the Kaplan-Meier method. So all children who came to our hospital underwent a brain MRI, brain and spine. They were targeted for a complete neurosurgical resection in most wherever it could be done. Less than 3 years did not receive any radiation, and they were directly taken up for adjuvant chemotherapy. More than or equivalent to 3 years received the craniosspinal RT with posterior fossa boost followed by adjuvant chemotherapy. We follow the POG 9031 protocol at our institute, wherein after the radiation, we give 10 cycles of chemotherapy. The first 3 cycles are given 4 weekly with cisplatin etoposide, and the next 7 cycles are given as vincristine cyclophosphamide. We do a baseline CBC, LFT, KFT, and hearing test. KFTA and hearing test are in red because we know that we have to look for late effects by cisplatin and radiation. So coming to the results, brain tumors less than 18 years of age who were registered in our department were 182. Of them, those who took treatment were 80. Of those 80, 43% were medulloblastoma, that is 34 patients. So my further slides would analyze these 34 patients. So more than 3 years were actually 28, more than or equivalent to 3 years. We also had 3 infants who were less than 1 year of age. The median age of presentation was 6 years and 70% were males. Most of them presented with headache, vomiting, focal neurological deficits in form of unsteady gait, diplopia, cranial nerve palsies. Other associated symptoms were irritability, feeding issues, loss of weight, and fever, and they were more commonly seen in the younger age group. The median duration of symptoms was 2 months. So most patients on their radiology, while I reviewed their radiology, had a very classical presentation. The staging workup as per modified Chang staging revealed that 45% were high risk. There were 35% who were metastatic, 20% with leptomeningeal disease, and 19% with spine seeding, and 15% who were CSF positive. Neurosurgery was done for all patients. However, there were 30 patients who actually had a GTR or an NTR. There were 4 patients who had a residual disease of more than 1.5 centimeter cube. CSI could be given in 100% of patients who were more than or equal to 3 years, that is those 28 patients. However, the average risk received a CSI of 23.4 gray, high risk 36 gray, and a posterior fossa boost was common for both, that was 54.6 gray. Chemotherapy was given to all the patients as I've already described with tolerable toxicities. Histology was pretty same as shown in literature, that is classic was more common, followed by desmoplastic, and anaplastic and extensive nodularity were trivial. Molecular analysis was only available for 8 patients. That is because we just have the past 4 years that we have started sending molecular analysis. Now we have it in-house also. So of my all patients, 29 achieved CR, and then of 5 actually had progressive disease. Of those 5, 4 died. 4 relapsed. Of those 4, 3 died. And presently, there are 25 patients who are alive and disease-free. 2 patients, 1 out of progressive disease and 1 out of relapse, who are alive with disease. One is an infant who did not receive radiation in the initial treatment. He relapsed. We gave ICE protocol as salvage and then proton therapy. The other patient who's alive with disease is a relapsed patient. He is on some alternative therapy. The median follow-up was almost 15 months. The EFS and OS was almost same because those who relapsed or those who had progressive disease did not survive. However, so it was about 58%. However, there was one child who relapsed at 64 months, had a very late relapse. So if I excluded that patient, then the EFS and OS was actually 66%. But because of that one patient, the whole thing came down by 10%. These are two very interesting curves of children EFS with less than 3 and more than 3 years. If you see, I don't have a pointer, that those who were less than 3 years, all the events happened within the first few months. And then there was a plateau. So if they survived, they survived. Similarly, in high risk and average risk, they had all the events during the first few months. Again, a plateau, if they survive, they survive. So probably it depicts the biology of these high-risk patients. To conclude, so as in the case of most pediatric solid tumors, multidisciplinary treatment is the way to go for modest outcomes. With conventional risk stratification, outcome is similar among average and high risk in our cohort. Events occurred early in the course for high-risk patients and those less than 3 years of age. Molecular classification may change this in future. Relapsed refractory medulloblastoma are challenging and not salvageable, and hence first chance is the best chance, the last chance, and the only chance. So optimization of frontline therapy is important. And this is my favorite slide of all this slide. These are more than 1,000 EST survivors. And this is our champion medulloblastoma survivor. He's 10 years of therapy. He has done MBA from IIM. He's the leader for Ashaya group. That's our survivor group. He's a content writer and an inspiration for all of us. Thank you.
Thank you, Dr. Payal. Question from the yes.
While I had one comment, in your flow chart showed the type of surgery was complete surgery. Huh? There is difference between the complete, near total
and near total.
Yeah,
Yes.
The words are very specific as far as the surgeries. Moreover, you have again showed in your inclusion criteria, the doses were for the CSI were up to 34 gray, but in your results, they were, you can cross check your slides. And what was the concurrent chemotherapy doses?
I had put that also.
Yeah.
So for cisplatin etoposide, cisplatin was 90 mg per meter square day 1. Etoposide was 150 mg per meter square on day 1.
What about the toxicity and treatment interruption for this patient?
So ma'am, I mentioned that all the patients, they tolerated chemotherapy pretty well without any significant toxicities. We do not encounter too many febrile neutropenias or
really
admission.
amazing. There is no
Yes,
treatment
ma'am.
interruption.
No interruption. No significant interruptions.
Etoposide and platinum.
But
you can
ma'am-
cross check. Okay.
Yes,
Thank
ma'am.
you.
We have analyzed that part and therefore I put it that they were tolerable talk. Nothing significant that was statistically significant that I have to put. Yes, ma'am. So after radiation, there is a gap when we start chemotherapy. However, there was no interruption in between.
Thank you, Payal.
Next speaker is Ravi Sharma. So role of cavernous sinus extension and MRI in T2 hyperintensity in the extent of resection following transnasal spinoidal surgery for giant pituitary adenoma.
Good morning, everyone. My topic is role of cavernous sinus extension and role of T2 hyperintensity in section of giant pituitary adenoma. So how do we define giant pituitary adenoma? It's on the basis of classification by Sivan et al., where it shows that extension of tumor greater than 40 mm above the plenum sphenoidal in any direction, less than 6 mm distance to the highest point of the tumor to the foramen Monro, and multi-compartmental spread. So in this study, we included all the adult patients within 18 years of age with a biopsy-proven pituitary adenoma who had a radiological diagnosis of giant pituitary adenoma and were operated with a primary transnasal transphenoidal approach in the last decade. And we perform a volumetric analysis using MRI at follow-up of 3 months. And we try to assess what are the factors clinically or radiologically which predict the extent of resection. And we did not include the primary patients who underwent primary transcranial surgery or recurrent tumors in this. So this is the outline of the study. We had 60 patients which were operated over the course of 10 years. And initially, we were doing microscopic transphenoidal surgery. And then we shifted gradually from microscopic to endoscopic surgery. And this is a outcome, and we showed that there was significant amount of patients who were having gross total or near total resection in both the microscopic as well as the endoscopic group, and there was one patient which was taken up for a simultaneous endoscopy plus a transcranial surgery. So these are the basic surgical steps showing the positioning, the lateralization of middle turbinate, the creation of nasoseptal fat, and the identification of sphenoid ostia, followed by a sphenoidotomy, drilling of the cellar floor and tuberculum cellae, the dural incision in the form of a T shape, and removal of tumor, followed by the skull-based resection. These are basic steps which are usually done in endoscopic surgery and can be extended further in the form of extended endonasal approach, which was the main approach in this study. So, as far as the experience is concerned, we found that majority of the patients presented with visual decline, and in 60 patients, we are having both functional component as well as a non-functional component. And another thing we found that in patients, there were 18 patients who had a paracellular extension with NOS 3A in 4 and 3B in 2 patients, and NOS 4 in 12 patients. The NOS 4 extension was found to have a higher proportion of subtotal resection. What we realized is that in endoscopic group, in the endoscopic TNTS group, as compared to microscopic group, there was significant amount of patients who were having GTR or NTR resection. And we assessed various parameters, and we found that subfrontal extension, cavernous sinus extension, multilobulated tumor, and T2 hypointensity were having a significant impact on the extent of resection as far as the univariate analysis is concerned. And multivariate, we lost the significance of multilobulated tumor, and only cavernous sinus extension, subfrontal extension, retrocellular, and T2 hypointensity has significance. And when we tried to do an alluvial analysis, and we found that the patients who had both cavernous sinus extension and T2 signal hypointensity were found to have a significant probability of subtotal resection. So these are the alarming signs. These are the signs which a surgeon should note in a preoperative period, which gives an idea that these patients are likely to have a subtotal resection, and this should be counseled to the patient as well. As far as visual outcome is concerned, more than 60% of the patients had improvement in vision. However, the duration of visual symptoms was found to be significantly associated with the postoperative improvement of vision. So our patients who were having visual deterioration less than 1 year, so they were found to have better visual improvement as compared to patients who had long-standing visual loss. So this is a surgical endocrinological outcome. Non-functional tumors also had a good outcome with need for hormone replacement in approximately 60% of the patients. And similarly, the functional tumors had a significant good outcome with good remission rates. The most common complication was diabetes insipidus, and in 4 patients, we had deterioration of vision in the post-op period also. So this is our rationale for the surgical approach. Conventionally, we prefer an endoscopic approach. If the tumor is extending to the retrocellular subfrontal parts, we can extend the boundaries to endoscopy. And if the tumor is going into the lower portion, then primarily transcranial approach should be approached, or a combination of approaches should be used. These are the preventive cases showing giant pituitary adenoma with good resection, with subfrontal resection, with cavernous sinus 3A extension, and in cases where we performed a combined transcranial plus endoscopic approaches. And in some cases where we had apoplexy, it is very important to urgently decompress the tumor using transcranial approach. And the literature also supports that today endoscopy is having better outcome than microscopy as well as transcranial approach. So to conclude, utilization of endoscopic approach helps in decompressing tumor much better than microscopy as well as transcranial. Retrocellular subfrontal cavernous sinus extension are actually poor extent of section, and in case of apoplexy, you need to go under a transcranial surgery emergency so that will prevent the neurological deterioration. Thank you.
Any question from the house?
That the T2-weighted hypointensity, the tumor, was a factor which prevented you from doing a cross-total resection.
Yes, sir.
So what do you think is the basis for that?
So reason is generally tumors which are T2 hypo tend to be more fibrous. So when you go in, especially in endoscopic surgery, it is very difficult to remove the fibrous tumor, and we end up doing a subtotal resection only. So in such cases, what is ideally should be done, we have realized retrospectively, we can stage the surgery. We did in around 7 cases, and you can remove the portion which is directly and comfortably without damaging any neurosurgery. And the remaining part can be done either in the staged transcranial method or maybe in 2 or 3 days, or maybe it can be done in the same sitting also. So that is very important because tumor is very fibrous, and it is very close to optic nerve and carotid bilaterally. So if you try to be aggressive in such tumors, you end up doing a neurovascular damage. And there's a carotid injury, which we had in one case. It is catastrophic. Yes, sir. We did correlate, and we found that it is a significantly liable if the tumor is homogeneously T2 hypointensive. So thus cases, it is always preferable to counsel the patient pre-operatively that we will have to do a second surgery, or already position the patient in such a way.
Did you say that this operative consistency at surgery, did you look at it?
No, sir, we did not do that analysis specifically. We realized it in retrospect because it's a retrospective study.
Thank you,
Okay.
Dr. Thank you. Now we had next speaker, Dr. Riti Talukdar, and topic is comparison of setup margins between 3 frameless stereotactic head immobilization devices treated with linear accelerator-based stereotactic radiosurgery.
Thank you. Very good morning. So the study is a comparison of setup margins between 3 frameless stereotactic head immobilization devices. All the patients were treated with linear accelerator-based stereotactic radiosurgery. So at the outset, I would like to put that I have no commercial interest in presenting this study. So these were the 3 masks that we had compared: the brain lab mask fixation system, the CIFCO 2-point arc with the Bayesian and the bite immobilization, and the last one is the POCL mask. The introduction of frameless stereotactic immobilization devices improved patient compliance for one, and also it has led to a varied practice, be it a differential fractionations used by different radiation oncologists, or a difference in the PTV margins. So with this study, I aim to find out and quantify the setup accuracies of patients undergoing single isocenter LINAC-based SRS, and to identify the factors that impact the same. So for coming to the methods, all the patients who were receiving fractionated or non-fractionated SRS for benign or malignant lesions were included in the study. The workflow was like this. So the CT simulation was done with the SRS, with the respective SRS frameless immobilization device. Target volume delineation, plan approval were done as per the discretion of the treating radiation oncologist. Patient positioning was done, and then the first CBCT was taken. It was matched using rigid registration algorithm, and then the shifts were recorded and applied. Our second CBCT was taken as per the discretion of the treating radiation oncologist. Shifts were applied again if necessary. Treatment was delivered, and after the delivery of the treatment, the third CBCT was taken in selected cases who had significant shifts in the previous CBCTs. Now, these setup margins were calculated using Stroom and Van Hoek formula. The mean 3D vector was computed for all the individual patients, and the factors influencing the margins were analyzed using Man-Whitney U test. So we got a total of 143 fractions from 36 patients treated between Jan 2021 to June 2022. Coming to the fractions, fractionations used. So the majority of our patients, 63% of the patients were treated with 5 fraction treatment, and we had single fraction as well as 3 and 4 fraction treatments too. Approximately 60% of the patients were treated for brain metastasis, and the rest of them were benign. Coming to the fractions, approximately half of the fractions were delivered using brain lab mask. 1/3 were done using the CIFCO mask, and the rest of them were done using a POCL mask. Now, this is a hyperplane plot showing initial and the residual translational shifts in all the 3 dimensions. And we tried to represent this particular data in a scatter plot. And as you can see, it's a busy slide. All the A on the left-hand side are
the data that we have taken from the initial CBCT, the first CBCT, and all the these are the data that we have taken from the second CBCT. So the residual values, and that can be represented them for all the patients, for the patients who were treated with brain labs, the fractions that were given with POCL and the fractions for CIFCO. And if we look at the residual shapes for these fractions, we can see that this for the shifts were significantly less for the CIFCO mask. Now coming to results, so all the initial shifts and the residual shifts were calculated, and the systematic and the random error were calculated from them. The P-table margins were calculated from the residual shifts using the Stroom and Reinert formula, and for the entire cohort, the P-table margin, the maximum P-table margin was of 1.4 millimeter. However, for the cohort that were treated with CIFCO mask, it was the maximum P-table margin suggested was 0.46 millimeter. The mean vectors were also calculated, and these are the mean vector values for the initial and the residual vectors. When the residual vectors are compared using the man-who test, the CIFCO and the brainless, the CIFCO and the brain lab fractions were significantly better in terms of residual shift than the POCL immobilization device, and CIFCO was again better than brain lab when compared between these two. We tried to correlate the difference, if there was any difference between the vectors when if we try to see between the date of simulation to the date of delivery, and there was no significant correlation. There was, however, the initial shifts were significantly less, favoring the infertemporal targets as compared to the supratemporal targets. Now to conclude, CIFCO provided the best immobilization, followed by brain lab and followed by POCL. If we are to give a P-table margin with appropriate use of CBCT, suggested P-table margin would be 1 millimeter for CIFCO and brain lab. However, for masks like POCL, we would like to suggest a use of P-table margin of 2 mm, and that this decrease in setup accuracy may be owing to the absence of mesium in the bite block. Thank you.
Thank you, Dr. Reddy. Any questions from the floor?
Dr. Reddy, I must congratulate that at least you tried to do something very innovative. I presume that this is not a randomized how do you decide upon that which particular mask you are going to use? Because majority of the patients, what you mentioned, 71 patients were brain lab, So how did you decide that which particular device is going to be used?
So it was one, first of all, based on the availability at the point of time, and secondly, also the size of the target, the fractionations that we had in mind to treat this patient.
No, does the fractionation decide upon which immobilization device you are going to use?
Not directly, but if we are using a mask that has better immobilization in terms of bite and mesium, we would be more confident in giving a single fraction with a lesser PTV margin, probably with dose escalation. We would like to fraction it if we are having to use a larger PTV margin.
And second thing, in the result, you told that the margin was minimal when you were using the CIFCO mask, only 0.4 mm. That is what you told. But the number of patients what were included in the CIFCO was also less. It was just 25 patients.
The fractions were 1/3 of the fraction of the entire fractions. Half of them were brain lab, and 1/3 of the fractions were delivered using CIFCO mask. Rest of yours.
Thank you, Dr. Ritti. The strength of any study is the study design. So next time you can try the good study design. Thank you.
Can I ask a question?
No, the time is over. We are going to the next speaker, Dr. Shalini Suman, and our topic is risk stratification of IDH mutant adult diffusely infiltrative astrocytic tumor based on CTKN deletion and P16 ISC.
Good morning, everyone. The topic of my presentation is risk stratification of IDH mutant adult diffuse gliomas based on CDKN2 deletion and P16 immunohistochemistry. Gliomas are the most common primary CNS tumor, accounting for 30% of all CNS tumors and 80% of all malignant brain tumor. In current WHO 2021 classification, all IDH mutant diffuse astrocytoma are considered as astrocytoma IDH mutant, which has incidence of 11 to 15% of all astrocytic tumor. The preferential site for this tumor is frontal lobe, affecting mainly adult patients with the mean age of 38 years. For the better management of the patient and prognostication, the grading is important. Various studies have demonstrated CDKN2A deletion is associated with shorter survival in patients with IDH mutant astrocytomas. Thus, WHO 2021 classification introduced CDKN2A homozygous deletion, which if present will lead to the diagnosis of WHO grade 4, even in the absence of microvascular proliferation and necrosis. But the deficiency in this classification was the absence of any defined cutoff for the homozygous deletion and the clarity about the testing modality. Also, worldwide, there is scarcity of literature about the frequency of CDKN2A deletion and its correlation with P16 immunohistochemistry. Thus, in present study, we assess the frequency of CDKN2A deletion in astrocytomas, assessment of P16 expression in diffuse astrocytoma and its correlation with CDKN2A deletion. We also correlated CDKN2A deletion with histopathology findings, tumor grade, MIB1 labeling index, P53 and ATRX mutation, clinical radiological findings, and follow-up wherever available. To achieve these objectives, we conducted ambidextrous study on 150 cases comprising of 95 grade 2 and 55 grade 3 astrocytomas. In all the cases, we first evaluated histomorphology using H&E slides, and then we analyzed molecular alterations like IDH, ATRX, P53, P16 expression using immunohistochemistry, and then CDKN2A deletion and 1P19Q0 deletion were analyzed using this platform. Coming on to the result, in a cohort of 150 cases, we had 95 grade 2, 50 primary grade 3, and 5 recurrent grade 3 tumors, and most of the patients were male. The ongoing molecular profiling, all the cases were IDH mutant with the mean MIB1 labeling index of 4% and 13% in grade 2 and grade 3 astrocytomas respectively. Majority of the cases showed loss of ATRX expression and P53 positivity on in both the tumors, both the grade of tumors. Coming on to the main molecular marker, that is CDKN2A homozygous deletion, considering 30% as a significant cutoff for the deletion, we found none of the grade 2 were demonstrated CDKN2A deletion. Amongst grade 3, 8% of primary and 40% of recurrent tumors demonstrated CDKN2A deletion. We further on integrated diagnosis after molecular profiling, we found 6 cases which were having histomorphology of grade 3 were labeled as grade 4 only on the basis of CDKN2A homozygous deletion. We further correlated CDKN2A deletion with various parameters, starting with our histomorphology. We found that all the cases which were reclassified into grade 4 showed significant anaplasia in the form of marked cellularity, marked nuclear polymorphism, and formation of tumor giant cell. And also there was significant brisk mitotic activity in the reclassified grade 4 tumors. On correlating with P16 expression, we found out of 34 cases which showed loss of P16 expression, 6 out of 34 cases showed homozygous deletion. Interestingly, none of the cases with retained P16 expression showed CDKN2A deletion. We had 5 cases for which we had parent as well as recurrent tumors. Amongst the parent sample, none of them showed CDKN2A deletion, while on recurrence, all the cases were grade 3 on histomorphology. On molecular profiling, we found 2 out of these 5 cases demonstrated CDKN2A deletion and were reclassified as grade 4. The gist of my result was that the frequency of CDKN2A deletion is significantly higher in the recurrent cases showing anaplasia, and cases showing loss of P16 expression. The survival analysis was that both CDKN2A deletion and loss of P16 expression was associated with poor overall survival as well as progression-free survival. In summary, we would like to recommend the administration of this platform in subset of cases showing anaplasia, brisk mitosis, loss of P16 expression, and recurrent cases. foretelling a higher risk of this alteration. By applying this selective approach in our study, we found 100% sensitivity and 100% negative predictive value. To conclude, I would like to say CDKN2 deletion is absent in grade 2 tumors, very rare in primary grade 3 astrocytomas, while it was very frequent in recurrent tumor. Though CDKN2 deletion is associated with poor overall survival and progression-free survival, the result was not significant owing to the rarity of this deletion. Also, to use this as a cost-effective manner, I would like to say that this assay should be used in the cases showing anaplasia, breast mitosis, and P16 expression and recurrent cases. And by doing so, we can actually save 40% of expenditure, especially in resource-constrained centers. Thank you. Any questions?
That was very important and relevant. Thank you. Did you correlate if this was independent of actually everything else from the ATRACS, 1P, 19P? What I'm trying to allude to that if this was independent, potentially use this as a tool in setups which are not neuropathology expertise and start grading it into a separate.
Sir, actually, these are the inclusion criteria was IDH.
I saw that. Yeah, so I'm saying, but do you feel or do you have data from others that this could be independent of IDH? This is somewhat easier to do than because we have very few neuropathological expertise in the country as a whole. So I'm looking at answers where in a non-expert area, some testing can be used to classify rather than.
Sir, that is what I did in my study.
I know. I saw that, and I'm saying that. So, but the point was that in IDH mutant there is a very strong correlation of badness here, right? So I'm saying if we were to, because the IDH mutant itself is a neuropathological expertise area, so you will find a lot of areas where tier 2, tier 3 cities, the patients get misdiagnosed, they come with early with rectal disease and they could have been higher grade that time.
So the point is that IDH testing by IHC is, I think, now more widely available.
Even still in neuropathological pathology. So, but there are a lot of patients where brain tumor is done.
Agree. Speaker and audience, still we require more educational and awareness program. Definitely we have to accept still most of the center available, but still more educational programs has to be promoted for the sustainability. This is the era of the molecular analysis, and we have to be like molecular oncologist and whatever we have to be molecular at this time. Thank you.
Yeah, coming to the last presentation, Sushant Kumar Shahu. His topic is factor determining the extent of tumor resection in eloquent area glioma surgery.
So, good morning, everybody. I'll be speaking on the surgical strategies determining the extent of resection and preservation of function in eloquent area glioma surgery. So, total 68 patients operated between January 2019 and 2022 were included. Age range from 18 to 66 years. There were 38 insular glioma, 18 premotor area glioma or close to the motor area, 12 temporoparietal glioma. The commonest presentation was seizure followed by headache, followed by focal neurological deficit in the form of monoparesis, hemiparesis, or speech disturbances. So the evaluation was done separately by a neuropsychological team who independently evaluated all the patients in the preoperative and the postoperative period. But intraoperatively, all the patients were assessed for the cortical mapping of the speech and language and the subcortical mapping of the white fiber tracts. The tracts chosen were the corticospinal tract for the motor mapping, inferior fronto-occipital and inferior longitudinal fasciculus for the semantic error, superior longitudinal fasciculus and arcuate fasciculus for dysarthria or the phonemic errors. The current used was 60 Hz, 1 to 1 millisecond, 1 to 4 milliampere. So this is the chart showing the disposition of the tracts. In majority of the tumors, the tracts were either continuous or displaced. only in few cases, the tracts are disrupted and they may or may not correlated with the clinical deficit. Then coming to the surgical factors. First, the use of the neuronavigation in deciding the extent of craniotomy, which would be adequate for the mapping, intraoperative mapping. When the preoperatively the neuronavigation was used and the craniotomy was mapped, the craniotomy was adequate in 100% of the cases for intraoperative mapping. However, it was adequate up to 80% in majority of the cases of insular glioma and premotor area glioma, and it was inadequate in all the cases of temporoparietal glioma if it was not, the craniotomy was not properly planned. So this is an example of a left insular glioma. After positioning of the patient, intraoperatively navigation was used and the craniotomy flap was planned, and intraoperatively the cortical mapping was absolutely adequate. Coming to the second factor, the tumor resection guided by the disposition of the white fiber tracts. Particularly this is helpful for the tumors which are very close to the premotor area or the motor tracts, where the motor tracts, as it is marked here in green color, it may be displaced anteriorly or posteriorly to the tumor, so it has to be seen properly. So when it is evaluated in all the 18 cases in our series, when in 13 cases the trajectory was planned, 2 patients had transient aphasia, and when it was not used, 3 patients had post-operative deficit, 2 had dysarthria, probably because of handling of the superior longitudinal or arcuate fasciculus, and 1 had conduction aphasia. This is a newer concept of using a suction stimulator, as well as it will act as a navigation. Can somebody play the video, please? Can somebody play the video, please? So towards the end of the resection, if a monopolar stimulator can be co-registered with the navigation system, it can directly show the disposition of the tracts towards the end of surgery, so that bit of tumor which is close to the motor fiber tracts can be removed without or with minimal functional neurological deficit. And this is the end. After complete resection of the tumor, this is the areas where the corticospinal tract got stimulated, and the posteriorly, the superior longitudinal fasciculus or the arcuate area where the patient had some phonemic error. So the cortex over that the tumor is preserved. Next question is whether to continue the resection till you get a positive stimulation. If we continue the resection till you get a positive stimulation, we'll end up with improvement in resection. More than 90% tumor volume resection was better in all these 3 groups of insular glioma, premotor and the temporoparietal glioma, with the deficit which are comparable if we stop the resection before getting into the positive stimulation. So this is an example. So the first case was operated without mapping in the time of COVID. It is the patient was operated with intraoperative ultrasound, but the patient landed up with focal neurological deficit. Play the video, please. The second case is almost a similar case. The patient was operated with intraoperative mapping. The patient is play the video, please. The patient is absolutely fine 6 months after surgery, and the post-op radiology is showing a good resection. Then these are few of the examples of left-sided insular glioma. The left upper row is showing a young patient who was operated with intraoperative mapping. It's a good resection. The patient went back to his working life. And the upper right side is she is a housewife. That young lady, the frontal glioma extending up to the insula, almost complete resection. The lower is a physician, 60-year-old physician who was out of his clinical works because of the cognitive deficit. The patient was operated with intraoperative mapping, post-op radiology showing almost gross total resection, and the patient is back to his clinical work after 3 months of surgery. So these are the complications. Among the insular glioma, 3% had residual paresis at 6 months of follow-up, 1% had cognitive decline and memory deficit, still 6 months follow-up. 2 premotor area glioma had residual paresis, and 1 temporoparietal glioma had paresis. So there is a change in trend with experience. In the initial 20 cases, we had complication of 4 patients. In the second 20 cases, we had complication in 3 cases. And in the third phase of 28 cases, only 1% had focal neurological deficit. However, the resection rate improved significantly. So this is the new concept. Everybody are talking about the parcellations. We got the opportunity to operate 1 case with the help of Professor Charles Teo. This young lady was operated along with the help of the parcellations, which are prepared with the QuickTerm software. And the post-op radiology is showing almost good resection, and the lady is back, and that girl is back to her clinic, her working life. So to conclude, functional preservation in eloquent area glioma surgery requires proper intraoperative functional mapping and preservation. The craniotomy has to be planned properly so that it should be adequate for intraoperative mapping. Navigation of the deep white fiber tracts are extremely important in the initial stage, so that their orientation deep inside the tumor cavity should be okay, and use of a continuous tracking system, if available, like a suction stimulator, is extremely helpful. And last but not the least, anatomical and functional understanding usually improves with experience. Thank you. Thank you, sir.
I would just add two things. Disturbance in the initial phase doesn't count to a permanent this thing.
Yes,
With
sir.
time they
Yes, sir.
improve. So you must remember that.
Yes, sir.
And the patient has to be counseled for that. Because initially
Yes,
they
sir.
might get very distraught that despite all the best center, the best quality, best things, I'm not having the deficit. They will improve, and a little bit of rehabilitation program helps.
Yes.
The other thing I want to ask you is, are you doing that? They are all awake, or you
All
make them
awake.
awake in between? There are two ways of doing it. You put them to sleep, do this thing, and then
So
make them awake.
initially, with the staging, initial stage, it used to take some 7-8 hours for a complete resection of insular glioma. So we were dependent on sleep awake. But with time now, the entire surgery is taking around 3 to 3.5 hours. So complete awake. Now we have switch over from the sleep awake to complete awake.
Right.
And the anesthesiologists, they are also comfortable.
You didn't show much of premotor, or you want to have different talk on that?
Actually, within 5 minutes, it is very difficult to describe all this.
Anyway, thank you very much. It's really very good job.
Thank you, sir.
Thank you, all the speakers, and it is conclusion of this paper presentation session. Thank you.